Welcome to the Kaleidoscope, Healthcare in a Diverse America, from molecule to market, with your host, Sheila Thorne. Each episode highlights healthcare leaders and patients of color to discuss culturally, linguistically appropriate strategies and services. You can find this show on all major platforms, including YouTube, LinkedIn, Apple Podcasts, Spotify, and on our website, SheilaThorne.com. Now here's the host of the Kaleidoscope, Sheila Thorne.
December 2nd was World AIDS Day. It was designated as such in 1988. 39 million people are living with HIV today, globally. In 2022, 1.3 million people became newly infected. I got involved in the HIV arena in the late 90s. At that time, I did focus groups in about 15 cities with HIV-infected individuals, gay, lesbian, transgender, LGBTQIA across the country to find out how they were faring with the disease, when they were diagnosed, how they were treated, how they were being treated. I then worked with one company and I set up a program called Project Soul. Soul stands for Serving Out of Unselfish Love. And we paired a newly diagnosed HIV Black or Latino with a veteran, somebody who was living with the disease, who literally took their hands and walked them through the process of what to do after diagnosis. Then for another pharmaceutical company, I established something called the HALT Council. HALT stood for HIV African American Latino Treatment Council. And I had the privilege of bringing together the nation's leading infectious disease specialists, Black and Latino HIV treaters. And I had the privilege over 3 years of doing community outreach workshops at the National Minority AIDS Council annual conference. So it's been a while since I've been in the HIV arena, but clearly today we're going to focus on where do we stand today. We've just come through COVID-19, the pandemic that globally impacted the world. HIV had the same effect back in the 80s and the 90s. But different groups are affected by HIV differently. Sarah, would you bring up the slide to show exactly how we are faring with regards to Black and Latinos with HIV? More than 40% of new infections, HIV infections in the United States, occur among Black people. In 2019, 14,300 African Americans were HIV infections, 10,200 Hispanic Latino, compared to 8,600 whites, Asians 550, and the data regarding American Indian, Alaska Native is not reliable and is scant and almost non-existent. So we are still within this HIV infection period on a global basis. You can take down the slide now, Sarah. Racism, systemic inequities, social and economic marginalization, residential segregation are key drivers of the disproportionate impact of HIV and AIDS. New infections disproportionately affect Black, gay, and bisexual men and Black heterosexual women. In 2019, 82% of HIV infections came from male to male sexual contact. People of color are less likely to receive HIV diagnosis, less likely to have access to PrEP, and one of my guests is going to talk about PrEP, less likely to be virally suppressed compared to white, gay, and bisexual men. Black women, 90% of Black women have contracted AIDS from heterosexual contact. It's the highest rate compared to all women of all races and ethnicities. Black transgender women in 7 states, 62% are HIV infected. So we are definitely within the communities of color, still very much within the HIV epidemic, which we called it then, but it clearly can be labeled a pandemic. Testing, connecting with providers, equitable access. 13% of Blacks still don't know their status. Asian and Hispanics, the data are not reliable. So we definitely have a long way to go. And clearly my 2 guests are going to shed light on what AIDS treatment and living with HIV was then and what it is now. Let me bring on my 2 guests, 2 of the nation's leading HIV treaters, and healthcare professionals. As you know, the Kaleidoscope is dedicated to bringing on board all professionals of color so that you can see the world through their lens in this particular therapeutic category. First, let me introduce Howard Smith, a practicing physician assistant, board certified in internal medicine, family medicine, and pediatrics, and is a specialist in HIV treatment. Again, in addition, Dr. Howard Smith definitely is a broadcast commentator. I had the privilege of being on his shows in Connecticut, and he definitely gets the word out in community. And he clearly is a leader in the American Association of Physician Assistants. My next guest is Dr. Richard Torres, a native of the South Bronx. He's medical director and VP of medical affairs at Urban Health Plan in New York City and practices in Central Harlem and the South Bronx. Dr. Torres has treated HIV and hepatitis C and related conditions for the past 40 years. I think we're going to learn something from Dr. Torres.
I'm 42.
42. Okay. I stand corrected.
I am 42 years old.
Okay, there you go. He is board certified by the American Academy of HIV Medicine and at the Yale University School of Medicine. He's a national expert in the care of persons affected with HIV, hepatitis C, and those in transgender health. He has multiple publications, including The Health Status of Puerto Ricans in the United States, and is a frequent contributor to the Latino Commission on AIDS, where he serves on the board of directors. So I brought you the best and the brightest to help us gain insight on the HIV epidemic, or more appropriately, the pandemic. So welcome, Dr. Smith. Welcome, Dr. Torres.
Thank you. Thank you.
Let me start with Dr. Smith, because Dr. Smith definitely practiced in California. He's practiced in Connecticut. He's practiced in New Jersey. I met him when I was doing a panel for Robert Wood Johnson School of Medicine. And at that luncheon, he was being named Physician Assistant of the Year. So when I tell you I brought you the best, I brought you the best. Both of these gentlemen are completely committed to their communities and completely committed to striving for health equity, particularly in this arena. So Dr. Smith, tell us, what was it like a decade ago treating Black and Hispanic HIV positive patients wherever it was that you practiced? What do you recall? What do you remember?
You know, Sheila, I can tell you it's a long time, but I do recall just starting out, even as a practicing clinician myself, with some hesitation about wanting to even engage or, you know, to be honest with you, to touch some of those folks who have been diagnosed with HIV disease. I am happy to say that we've come a long way. That stigma has decreased for a number of reasons. We now have social media that was not around back in the days when I was just starting out. And those things have helped in some ways to give information as well as to mislead some of us with some misleading information as well. I'm happy to say that today we're really in a different place. We still have a long ways to go, and I'm sure Dr. Torres will touch base on that as well, but I'm happy to say we're getting there.
Yes, I remember, Howard, the days when you saw emaciated patients sleeping in hospital beds. You saw healthcare professionals armed with all kinds of biohazard gear because they weren't comfortable touching these patients. So it definitely was a time of a lot of fear, a lot of uncertainty, and a lot of misinformation. But we clearly have come a long way. And so your perspective to look back, but then to look forward on how we treat people of color with HIV/AIDS. Well, did you see any difference in the way patients were treated, white patients compared to Black and Latino patients?
Well, you know, there's clearly a difference between the haves and the have-nots. I mean, those folks who have access to healthcare, who have health insurance, definitely did receive much better care than the folks in marginalized communities, such as, you know, South Central Los Angeles and Harlem and some of those places that I've been privileged to care for people. I can honestly say there was a big difference in those communities, and those differences still continue to this day. You know, when we look at all of the legacies of the past history, when we look back at the Tuskegee and all of those ghosts that somehow we would like to bury, that we just can't seem to bury them, and I don't think we should until we address them.
Exactly.
Those are all factors that I think come into play today. With increasing access to care for people that look like you and I and Dr. Torres. Clearly, we have some ways to go. There's a lot of work to be done.
Well, homophobia, transphobia, stigma are still rampant in our community. And that may be some of the reasons why people hesitate to get tested, to get treated. I remember talking to some HIV patients who didn't know whether to tell their partner, didn't know whether to tell their families, didn't know whether to tell their employers. They were really in a fix regarding how to live with this condition. And at that time, it was terminal. It wasn't living with it. It was a death sentence. And so clearly, we definitely have to step up the pace with certainly people of color who are marginalized and who are not included in the system. So I thank you for your perspective and your presence during that time. I'm sure the patients were happy to see you when you came into the room.
Absolutely. We know that, when the provider looks like the patients we serve, there's a certain level of ease that brings. And as a result of that, more likely you'll have more compliance with treatment protocols and regimens when the patient can relate to the provider.
Definitely. Thank you so much for that. Dr. Torres, we're going to get in the weeds with you, okay?
Yes.
Because you definitely can shed some light on the arc of advocacy that has happened. And quite frankly, I think that the HIV/AIDS agenda really thrusts the pharmaceutical industry into being more open with people of color. It was the first time they reached out to people of color. So we were in that striving for equity, health equity back then, but it really has been laser focused today. And that's why this is so important. So Dr. Torres, is the HIV/AIDS epidemic over?
Sure. So Sheila, before I address that, first, I'd like to thank you for inviting me and Howard and putting this program together. Secondly, your comments were right on point. You hit the nail with your hammer, and every point that you brought up in your introduction was excellent. Matter of fact, you took a lot of my stuff, but that's okay.
It would be better coming from you, Dr. Torres.
I wanted to add to a little bit of what Howard had stated earlier. And I actually went to med school in Boston from 1979 to 83. And as a third-year medical student, it was the winter of 1981, when I actually saw a young white gay male with a brain infection called toxoplasmosis, which is an opportunistic infection in a patient with HIV infection. I also saw a child with hemophilia who had HIV transmission at that point in 1981. So some of the early cases then I saw very early on. And then when I went to residency in Philadelphia, and then of course ending up in Bridgeport, and over the years I've seen, and we'll talk about the development of medications and PrEP and so on over the last 4 decades. So in terms of your first question about is HIV, the epidemic, over, it is certainly not. I think you've already sort of pointed it out to a degree. We have seen a 73% decrease in the incidence of HIV infection since the onset. So since 1984 and 85 to 2023, we've seen a tremendous decrease, right, in new cases, which is what incidence means, new cases. However, it's not over. In 2021, as you mentioned, we had 36,136 new HIV cases in this country. More importantly, what it pointed out was that there were increases in, for example, a 24% increase in transgender people between the ages of 24 to 35. There was a 19% increase in the age group 35 to 44%. And there was a 7% increase in people over the age of 55.
Really?
So, yes. So, we'll talk about that a little bit later on too. By 2030, believe it or not, 2030, which is not too long from now, another 6-7 years, 70% of patients living with HIV in the US will be over the age of 50.
Wow.
So yeah, we're living longer. But we certainly, HIV is not curable.
Right.
It is treatable, right, to an effective treatment, but it is not curable. And our goal is to end the epidemic.
Interesting, Dr. Torres. That's fascinating, because most of what I remember about the HIV space is the complications, and the things that you mentioned were more the killers than the actual virus itself.
Exactly.
I remember talking to patients with Kaposi sarcoma as well. So those are the things that I don't think people really truly understand. But there's no cure. There's no vaccine. So we still have some work to do. So tell us, how has the treatment landscape changed? We started with antiretroviral therapy that was powerful. It killed the good cells and the bad cells. Then we went to cocktails and we went on from there. So where are we today with the treatment landscape?
Excellent question. So in 1987, in March, they approved AZT, which was the first and only medication used for HIV infection. That medication, I remember prescribing it every 4 hours, 6 times a day to patients.
Every 4 hours, wow.
Patients used to have a clock, a watch that would remind them to take it. At that time, the only test that we knew about that we had was detecting the amount of CD4 cells, the immune cells that the patient had. It wasn't until the early 90s when we had developed HIV viral load that we understood that some of the early dosing was toxic to patients and it caused them to have anemia and feel sick and nauseous. And then in the mid 1990s, 1994, 95, we had the protease inhibitors, which really changed everything, right? But it was called highly active antiretroviral therapy. And this is when patients in the late 90s were taking anywhere from 15 to 18 medications a day, sometimes 2, 3, 4 times a day.
Wow.
It was very difficult. In 2006, Atripla was the first single tablet regimen, one pill.
I worked on that, yes.
Right, to be taken once a day. And can you imagine, right now we have 14 different medications combinations that are taken once daily. So the landscape of treatment has advanced. The pills are smaller, they're less frequent in frequency, and they have fewer side effects than ever. So we become more effective than that. But despite that, though, believe it or not, we only have about 68% of patients with HIV who regularly take their medicine and are undetectable. That means that in their bloodstream, their HIV virus is below the level of 20 copies, only 67%. So that's one of our barriers and dilemmas.
Definitely. And Howard, Dr. Smith, do you remember prescribing AZT back in the day?
I'm sure, yeah, back in the day, definitely. And the issue with compliance around that, with the number of times folks had to take, this medication, that was a big deterrent for many of the patients that I recall interacting with. In many ways, I'm so happy I'm in pediatrics these days because while we know that between the ages of 13 to 24, that age group accounts for about 21% of the newly HIV diagnosed cases in the United States, of which I have no one right now in our clinical practice that I'm seeing with HIV. So I'm happy to say that.
Yes.
Looking back, back into the early 1993 when I was in Los Angeles, where we had a huge homeless population, mom, kids born to parents that were IV drug users. And looking where we are now, I can honestly say we've come a long way. And I'm just so excited hearing Dr. Torres talk about, the different types of medication once a day now.
Exactly.
In comparison to what we had back in 1993.
Yeah, there were only a handful of pharmaceutical companies making HIV products back in the day. Now we have a definite whole stable of possibilities. But Dr. Torres, all of the things you've mentioned, do Blacks and Latinos have access to these new therapies, these options for their treatment?
Yeah, I mean, there's always issues with access in terms of health insurance coverage. Many of the plans may not approve some of the newer medications that we do have on the market. Mind you, some of these medications are very, very expensive.
Yes.
And one of the things we do know is that, for example, you mentioned it. Maybe I'm getting a little ahead of us, but
please,
in terms of PrEP,
yes,
for the audience means using a medication called Truvada once a day, or a medication called Descovy. Those are the two that are approved. There is also an injectable approved for pre-exposure prophylaxis, which means preventing the acquisition of HIV infection from someone who has the infection himself. When you look at African Americans, only 14% of Blacks are on PrEP. Yet, as you mentioned, more than 41% are positive in terms of the new cases. In Latinos, only 17% are on PrEP.
Yet, why is that? Why is that?
They make up 29%. Part of that is essentially the providers not making it available in terms of considering the option. When you find a Black or Latino patient, an excellent sexual history should be ascertained. If a patient presents with a sexually transmitted infection, would mean that they're at risk. We should be discussing patients' history much more frequently. And sometimes, a lot of the Latino and Black patients will not discuss whether their sexual preference. They either have embarrassment or they're worried about stigma, as you mentioned, and other issues. So that's part of the lack. But the other thing is, if our patients and our people are going to the emergency room, where they get most of their health care and not having a primary care provider, they're not going to be offered PrEP in the emergency room. They're going to be told, see your primary care provider. And you know what happens then. And so, yes, it's important to get PrEP more access to more patients. We know that people on PrEP, in terms of sexual transmission, it reduces that to less than 1%. It's 99% successful.
My goodness.
Truvada is for preventing acquisition of HIV via sex. It's in terms of injection drug use, it's about 74% successful. But obviously, we would recommend changing syringes and things like this rather than rely on PrEP. PrEP, primarily in Truvada and Descovy, are for segments of the society. And so that's very important. It's
very important. And I think I can think of intravenous drug users, formerly incarcerated, people that have risky sexual behavior. Unfortunately, the mindset societally is these are throwaways. These are people who have the disease. It's their fault. They behave badly. And we've got to get rid of that stigma about this community. We have men who have sex with men. We have men on the down low. I mean, I went to San Quentin for one of my clients and talked to some of the inmates who were going to get out in 6 weeks. And one company was able to give them a 30-day supply of the medication, connect them with a provider in a halfway house. But that program went way by the wayside. Nobody kept up with it. The money was not there. And so when the face of AIDS got darker, Dr. Torres and Dr. Smith, the money dried up.
Yes. No doubt.
Yeah, and I think also when you throw in the mix those determinants of health into the play, that again takes you down another street. In order to heal it, we have to deal with it. And as I read recently, one person said that there's no greater sin than telling someone the truth in the 21st century. So if we are to be truthful, those determinants of health that are not addressed will always be below the surface, and we will never get to the true problem until we address some of those things.
And both of you have worked in community. You encourage community, educate community, boots on the ground, feet on the street. You've got to meet people where they are. And that's challenging for many companies who are not looking like those populations that they're trying to reach. So Dr. Torres, talk about TASP, TASP. What is that?
Yeah, that stands for Treatment as Prevention. So we know for several years now, there was a large study done called the IPER-GAY study, and it looked at the transmission of HIV infection in people who are undetectable. And what this study showed, and what we know for certain, is that if a person with HIV infection is on treatment and is undetectable, they cannot transmit the virus sexually to another person. When we first heard this information, we had doubt, especially those treaters for the last 20 or 30 years. But it is without a doubt effective as a prevention method. So if you have a partner who is HIV positive, that person must be undetectable and remain undetectable. So we have PrEP as one treatment. And you mentioned it earlier, Sheila. You said 13%, which is correct. 13% of our population are not aware that they're HIV positive. So one thing is that we have people that are positive and they need to be tested and diagnosed and get on treatment. I mentioned that only 67% of our people, or people with HIV who are positive, are undetected at this time, right? That means 1 out of 3 that is not undetectable, which means they're not taking their medications or they've developed resistance and they can transmit the virus to someone else. So the more patients that we get on treatment, that's called treatment as prevention.
Okay.
Important.
Well, that's extremely important. And again, it's about educating and empowering our people to take charge and control of their health. There are screenings available for HIV. In some jurisdiction, you can't pay for that. They're trying to dismantle Medicaid and Medicare, which often is the safety net for many of these populations to get tested, to get screened. I did surveys once in Harlem, and almost 90% of the people we spoke to knew how you got HIV. What they didn't know was what to do when you got diagnosed. Where to go, which provider, which medication. Do you both find that the case?
In pediatrics, I can say because kids' parents bring them to those appointments, that kind of thing. I have not seen that much on the pediatric side, but I do recall, in adult medicine, where that was an issue in the beginning. Many of the patients who, for whatever reason, because of stigma, did not want to be seen in the local facilities around where they live and work. So many of them would travel, long distances to see a provider just in hope that they could keep and protect their privacy. So that was more of an issue that I recall.
Yeah, and I could tell you that in adult patients, the issue is that many patients have comorbidities. They not only have HIV, but they have a behavioral health condition, whether it's simple anxiety, major depression, bipolar depression, schizoaffective disorder. So a good proportion of our patients have these behavioral health conditions. Substance abuse is another issue that also we find common in our patients who are affected with HIV. So that interferes with their medical conditions. And then, as we mentioned, patients over the age of 50. Actually, when the patient gets older, we find the older patients are more likely to take their medication than younger patients, which is
really interesting.
Especially HIV. In HIV, it's more compliance as you get older. You seem to have matured at that point. You've gone through everything in your life, and you realize how important it is. That's important. Sheila, I wanted to touch base too on something you mentioned a little earlier that had to do with how are we going to get to the end of this?
Exactly.
How is HIV, the pandemic, going to end? So there are different societies in our country. New York City has an end the epidemic goal. The UN has their own set of guidelines. For example, the UN has, it's called UN AIDS, and their goals are that by 2030, they call it the 95-95-95 rule or goal, meaning that 95% of patients with HIV will know their status. Right now, how many? About 85%, 87% know their status. So that could be achievable. The other 95% is 95% of people with HIV on treatment. Right now, we have only 65% of our patients are on treatment who have HIV. And the other goal is 95% of those on treatment who are undetectable, meaning that undetectable at 100%. Right now, we're at 67%. That's 7 years from now. I would love for us to achieve that goal. That would be very important. New York City has a more realistic, achievable goal. They want to reduce the number of new infections by 75% in the next 5 years and have 90% of people with HIV diagnosed, tested and diagnosed. So the CDC has also recommended for people in general, for all of us, between the ages of 13 and 65, that you have one HIV test done in your lifetime, right? As that's a standard of care. However, if you, very important. Once in your lifetime, at least once, but if you have risk factors that we've mentioned, and STI, for example, men who have sex with men, injection drug use, multiple partners, and the list goes on, that you should get tested more frequently. Okay? I'll say that we have a patient on PrEP, for example, Truvada. They have HIV testing done every 3 months.
Interesting.
So it's important that, and I think what I can tell you is that 20 years ago, 30 years ago, to do an HIV test on certain people, you'd ask them and they would be hesitant, not sure. They didn't want that tested. As it's become more of a standard of care, people are much more accepting of having the testing done.
Right. So there's no such thing when you hear news reports of people being cured with HIV. Is that an accurate statement? Has anyone been cured?
Yeah, they have. They're in only very few rare special circumstances. There have been a few under 5 cases of cure, but these are patients who had other medical conditions. For example, I'll tell you, a patient in particular had leukemia and had a bone marrow transplant, had a relapse of leukemia, had a second transplant. And when they transfused the patient, they gave him blood from a patient who had a genetic, it's called I forget the actual gene, but 1% of our population are resistant to acquiring HIV. They use that. And so they were able to essentially get this patient to a cure in HIV. And they continue to check the patients once they've gotten to what they believe is a cure. But it's still an incurable and not a practical treatment for patients with HIV infection. But I think, we're certainly getting closer from where we had been. And unfortunately, if we had the protease inhibitors a lot earlier, people like Arthur Ashe, Herring, and many other people would be alive today, unfortunately. And I think all of us have been touched by family and friends who have passed from the virus. So, it's important not to get the virus in the first place. Sure. And if you don't know your status, get their status checked. And if you're positive, get on treatment and stay on treatment. We also, by the way, on treatment, we have patients that are on multiple medications. And if they're virally suppressed and stable for 6 months to a year, there are indications to switch them to more simpler regimens. And you're seeing the commercials now on television frequently, and there are treatments with one pill that have 2 medications in it, when we used to have 3 to 4 medications. So now we're able to control the virus a lot better and reduce the long-term side effects of some of these medications.
Yes, we've learned a lot for sure. And if you were to say one thing, Dr. Smith, to the Black and Latino communities that Dr. Torres was talking about who are at risk, what would it be? What would your message be?
I would say just get informed, get tested, know your status.
Know your status.
Know your status.
Yes, and take action accordingly, or whatever it might be. Agreed. Dr. Torres, any final words for Black and Latinos who might be at risk for contracting HIV? You already said once every 3 months or regularly getting tested. What else?
Yeah, I think the key is that we do test. We need to know our status. And as Howard mentioned a little earlier, our patients should know that we as Latino and Black providers, for example, in this kind of medium that we're in now, are here because we want to be part of their family. We want to treat them as humans, and we want to help them. And we're all in this together. Things have improved dramatically, and that's why we're still working with them. So as Howard just mentioned, getting tested is critical. And then the patients who are positive, getting them to an undetectable level. And then the difficult patients, the ones with the mental health and substance abuse, those are the big challenges. We need to really address them.
Those comorbid conditions definitely have an impact. And as I said at the outset, racism, systemic inequities, social and economic marginalization, residential segregation are key drivers that prevent people of color from getting tested and getting into the system and staying in the system. Exactly. So we have to overcome those things. Nobody's going to do it for us. We have to do it for ourselves. And both of you in community always preach this message. And as Maya Angelou said, when you know better, hopefully you do better. So we've got to keep talking about this with our white providers as well, if they have HIV patients, to really encourage them to take charge and control of their health. It's critically important. We're living at a time when we're living very close together. Many Black and Latino families have multiple generations in one household. Millennials have a very different view of their sexuality. People are struggling with their sexual identity. A lot of complex factors that impact behavior and make you perhaps more vulnerable for HIV. So I hope this has given you both an opportunity to share your rich experience with our audience. We are a courageous, bold, and resilient people. We can overcome this. We can take charge. And the technology and the science is definitely on our side. I had the privilege of working with Dr. Fauci during the HIV epidemic when we were having many forums like this in the community. So the final message is take charge and control of your health. And that's why I wanted the Kaleidoscope to see the world through your eyes. People who look like you, people who talk like you, who come from where you come from. So I thank you both for your expertise.
Thank you.
God bless you for what you do. And hopefully our community will be reawakened to the HIV epidemic, which has not gone away. Thank you both.
Thank you so much.
Sheila.
Thank you.
Thank you, Howard.
You've been tuning into the Kaleidoscope, Healthcare in a Diverse America from Molecule to Market, with your host, Sheila Thorne. You can find more episodes on all the major platforms, including YouTube, LinkedIn, Apple Podcasts, Spotify, and on our website, SheilaThorne.com. Thank you for your positive reviews, comments, questions, and for sharing this show with others.